So these are my disclosures that really have nothing to do with this talk. So when we talk about PROTACs, we're talking about a small molecule that can target a specific disease-causing target protein. In this case, we're talking about the androgen receptor, and we're talking about making a trimer between the PROTAC, which is a protein degrader, the androgen receptor, and E3 ubiquitin ligase, which then goes on to induce ubiquitization of the target protein. We then have a proteasome that then degrades the disease-causing target protein, and through iterative degradation activity, this PROTAC can go on to then degrade hundreds of other androgen receptors. It can be used in other things as well, such as ER-positive breast cancer. And we know that 20 to 25% of men with metastatic CRPC develop mutations in the androgen receptor ligand binding domain. This can be L702H, H875Y, and T878A. And I'm going to speak about the PROTAC androgen degrader ARV-766 that targets both the wild-type androgen receptor and these three androgen binding domains. So I first worked with ARV-110. We developed this with metastatic CRPC, and the patients we found that had the best responses in metastatic CRPC and a radiologic progression-free survival of 11.1 months had either T878, H8, or H75 or wild-type androgen receptor. We were developing a phase 3 trial after the initial study. And then the company, just after we spent a lot of time developing, they just decided we're not going to take this one forward anymore. We're switching over and we're going to develop ARV-766. So I'm actually presenting slides from, I want to thank Dan Petrolak for his talk from ASCO 2024. We did participate in this trial as well. And there was a phase 1 dose escalation part. And then there was a phase 2 cohort expansion part. And patients had ongoing ADT, 1 to 3 prior ARPs, and less than 2 prior chemotherapy regimens. And the treatment was either with 100 milligrams or 300 milligrams orally daily. And you can see from this slide that there's 123 patients in both the phase 1 and the phase 2, and there's 53 patients that have AR ligand binding domain mutations. And of these patients, you can see there's 25% had visceral disease. In terms of prior lines of therapy, there are 4 as a median, so from 1 to 10 prior. So this is a heavily pretreated population. 100% had prior ARPI, and over 50% had more than 2 prior ARPs. If you look at the prior taxane, this occurred in almost 60% of patients, either in the ligand binding mutation population of 53 patients or in the total population. And if we look at this, there were no DLTs, and an MDT was not reached in the phase 1 portion of the trial. And this went on to phase 2, and across all 123 patients, both ligand binding mutation and all the rest of them, the majority of patients had at least 1 grade 3 adverse event. 2% actually had a grade 5 treatment emergent adverse event. This was not thought due to the drug, but they had progressive tumor. These were heavily treated sick patients. 37% had a grade 3 or 4 adverse event. And if we look at the patients with AR ligand binding mutations, there were 47 here that are noted, and the PSA 50 was 43%, and the PSA 30 was 51%. And if we look at the patients who had measurable disease, which is not so common in metastatic CRPC, that most of the patients have bone disease, but there were 20 of these patients, and you can see that the best response was 30% overall response, although not all these were confirmed. And then if we look at the AR ligand binding domain in 53 patients, you can see that some were continued on treatment out to 84 weeks. So many of the patients were still continued on treatment at the time of this ASCO presentation. So I just want to conclude that mutations in the AR ligand binding domain have been associated with poor prognosis in men with metastatic CRPC. In this phase 1/2 study of the PROTAC AR degrader ARV-766 in previously treated patients, heavily pretreated patients with metastatic CRPC, ARV-766 monotherapy was relatively well tolerated, and it showed promising clinical activity with a PSA 50 of 43% in patients with tumors harboring the AR ligand binding mutations. And I believe that this warrants further development in advanced prostate cancer. Thank you very much for your attention.